not as tall as Dr. Holtz, so I think it's still okay though, like this. I think this should be fine. But first, let me thank the organizers for providing the opportunity for me and my colleagues to present our work. So in the United States, HIV disproportionately affects men who have sex with men. And although recent data suggests that HIV incidence is declining nationally overall, the rates in MSM have not necessarily experienced the same decline. And in fact, the proportion of cases occurring in Black MSM is increasing. Life table analysis can be used to estimate the lifetime risk of HIV diagnosis within birth cohorts and can serve as an alternative method for assessing and anticipating trends in a particular population's risk, and also to draw comparisons between different populations, for example, between different racial categories. So in our analysis, we constructed life tables for the period from 1982 to 2012 to estimate the cumulative risk of HIV diagnosis among MSM in King County, Washington, born in 1940 to 1944. And we chose these birth cohorts specifically because they would have reached young adulthood during that period in 1982 to 2012. In order to construct those life tables, we first used US Census data to define the size of the white and Black male populations in King County in each age group. And then we estimated that 6% of the male population of King County is MSM, which is a higher proportion than some national estimates of roughly 4%, presumably reflecting a period of net in-migration to the Seattle area during young adulthood, which we adjusted for from age 18 to 29. We then used local surveillance data from the King County Electronic HIV/AIDS Reporting System to define the number of HIV diagnoses in MSM each year. So in this figure, we've plotted the cumulative risk of HIV diagnosis among white MSM. On the x-axis there, you see age in years, and on the y-axis, the cumulative risk of HIV diagnosis as a percentage. The blue line here represents the cohort of MSM born from 1940 to 1944. And as shown, these men were in their 40s when the AIDS epidemic started in the 1980s. So their cumulative risk increases until it plateaus at roughly 15% in their 60s. So in subsequent birth cohorts, so for those born in the late 1940s, the 1950s, and up to the mid-1960s, you see that the cumulative HIV risk increases significantly until we get to this peak risk cohort of those born in 1960 to 1964, who essentially were in their 20s when the AIDS epidemic started in the 1980s. And for these men, over 40% had been diagnosed with HIV by the age of 50. In later birth cohorts born after 1965, so those born in late 1960s and the early 1970s, you can see that risk declines significantly until you get to these later birth cohorts born after the mid-1970s, where it appears that the risk has plateaued at a lower level. So for example, if you look at the cohort born from 1960 to 64, the cumulative risk of HIV diagnosis by the age of 30 was somewhere around 20%, whereas for those born just a decade later in the late 1970s, that same cumulative risk of HIV diagnosis had decreased to 7%. This is a similar plot of the cumulative risk of HIV diagnosis, this time among Black MSM. Although you should note that the y-axis scale goes to 70% cumulative HIV risk as opposed to 45% on the previous figures for white MSM. But overall, we see similar trends in the cumulative HIV risk. So again, HIV risk increases for those born in the 1940s, the 1950s, to the mid-1960s. And again, decreases for those born after mid-1960s, and ultimately plateaus in these later cohorts at a lower level. In this slide, we more explicitly compare the cumulative risk of HIV diagnosis in Black MSM versus white MSM in selected birth cohorts. So the dotted lines represent 3 selected birth cohorts of Black MSM, and the solid lines represent the corresponding 3 birth cohorts of white MSM. So while there's a relatively small disparity between racial categories for those born in 1945 to 1949, that disparity increased in that peak risk cohort, that highest risk cohort born in 1960 to 1964. So that by the age of 50, for white MSM, about 40% had an HIV diagnosis, and for Black MSM, over 60% had been diagnosed with HIV. And it's interesting to note that that absolute disparity in that highest risk cohort, born from 1960 to 64, that absolute disparity is greatest there, and that the absolute risk decreases significantly for those born later in the 1970s. For white MSM, but even more so for Black MSM. So while there's there's an increase in the relative disparity, the absolute disparity actually decreases, for example, from 18% in those born in the 1960s to just 8% in those born in the 1970s. But throughout the period and across birth cohorts, cumulative HIV risk was higher in Black MSM by about 18 to 84%. So in summary, we found that when we look at sequential birth cohorts in MSM in King County, that cumulative risk of HIV diagnosis progressed in 3 phases. So first, it increased in MSM born from the 1940s to the 1960s, and that the highest risk was found in MSM born from 1960 to 1964, who essentially reached young adulthood, their early 20s, right as the AIDS epidemic started in the 1980s. This cumulative HIV risk then declined approximately 65% in those born after the mid-1960s and plateaued in later birth cohorts born after the mid-1970s. And this trend occurred in both Black and white MSM, although significant racial disparities do persist. The largest absolute decrease in risk actually occurred in Black MSM, although the relative disparities between the racial categories have increased in the later birth cohorts. Our analysis did have a number of limitations. So first, we used surveillance data, so we were not able to include unrecognized HIV infection. We also can't say how generalizable our findings are to other localities, given that our data is specific to King County. Our findings are also based on an estimation of the size of the MSM population, which is imprecise, although these imprecisions should not affect the trend estimates, just the absolute numbers. And with an increase in the number of racial categories included in the US Census, there could have been changes in ascertainment of race, although we didn't see significant anomalies in the proportion of racial categories over time. So in conclusion, our findings suggest that King County may be aging out of the HIV epidemic. And however, high rates of infection in young MSM, and particularly in young Black MSM in some areas of the U.S. suggests that this trend is not ongoing nationally across the board. And to the extent that sexual mixing is age assortative, the absence of progress in young MSM presents a long-term problem, as high rates of infection early in the life course appear to lead to high cumulative risk of HIV within a particular birth cohort. I'd like to acknowledge my colleagues listed here and also thank you for your attention. I'd be happy to answer any questions at this point.
Are there any questions from folks in the audience? Well, while he's coming, I'd like to ask, do you, the previous speaker spoke about environmental factors, civil unrest, floods that played a role in people accessing care and services. Can you maybe speak to or speculate, did you find, or can you even speculate about factors that played into the racial disparities?
Yeah, we didn't look at specific factors, but I think that if we go, can I go back? I guess I can go back, yeah. So if I can pull up this, I think it'll be hard to get to. But okay, so right here, if you look at the cohort born in 1945 to 1949, you see that actually initially those two lines are not too far apart. And that sort of, to me, represents the time at the beginning of the AIDS epidemic when there was not much information, not much awareness about prevention that could have contributed to those disparities, and that those disparities actually show up later on when there are those differences in access to care and awareness and those other factors. So we didn't address particular factors, but these trends kind of point to that to me.
Thank you. Sir.
Hi, Roger Pebbody from AIDSmap. It looks as if the data you're presenting suggests that there's something going on in Seattle that may be different from the rest of the trends in the US. Could you speculate at all about what's being done locally that may have an impact, a positive impact for Black MSM specifically?
Yeah, thank you for that question. So we are actually looking hopefully at other regions of the United States and other cities, including in the Southeast United States, Mississippi specifically, to see if these trends are similar there. And it's going to be very interesting to see if we see the same trends and if those same disparities exist. I think that overall that Seattle is, I wouldn't say unique, but Seattle does seem to have well, first off, a higher proportion of MSM than certain other cities in the United States, but then also higher rates of viral suppression. And so I think that it speaks to the awareness of the population and the sophistication of the population. I think that those factors likely play into it. But I'd be very interested to see some of those findings of our analysis later on in other areas.
Just a very quick one. Higher rates of viral suppression brings up a great point. I was just about to ask, do you have any details on the treatment cascade in the county and how those numbers play out? Eric Loya, California.
So I don't know the numbers off the top of my head, but I'm sure other people in the room probably could tell you that. But the viral suppression rates are higher in Seattle compared to nationally.
Susan Buskin from Surveillance in King County. Yeah, I'm bad with numbers, but I think that
Thank you, Susan.
Our estimate on the care cascade, including undiagnosed, is low 70s, and starting with diagnosed, low 80s. of percent suppressed. So it's pretty good, and part of that is because we have good denominators. We've spent a lot of time cleaning up our surveillance data and getting our out migrants out of our surveillance data.
Thank you.
That's not to say that the providers in King County aren't great, and the population's highly educated, higher income, so it's kind of different from other places in the country.
Thanks so much, Susan.
Thank you. Great job.
Our next